Hello, everyone. Thank you for joining us today for our webinar entitled Botulinum Toxin in Movement Disorders. My name is Dee Tran, Communications Editor for the International Association of Parkinsonism and Related Disorders, and I will be moderating today on behalf of the organization. First, I'd like to thank you, our sponsors, Ipsen and Merck, for their generous support in making this webinar series possible. Today is part of a whole series of botulinum toxin lectures. I hope that you will be able to join us in the future as well. Today's webinar consists of a 20-minute presentation to be followed by 10 minutes of questions and answers. Please type your questions in the chat box at any time. Also, you can help us serve you better in the future by filling out a brief evaluation form after the webinar. This webinar will be recorded and available on demand for up to 1 year at our website, www.iaprd.org. And now I would like to introduce you to Dr. Pramod Kumar Pal. He is the Professor of Neurology and Program Director of the Movement Disorders Fellowship Program at the National Institute of Mental Health and Neurosciences in Bangalore, India. His areas of interest are Parkinson's disease, dystonias, essential tremor, psychogenic movement disorders, spinal cerebellar atasias, and human motor physiology. He is the founding secretary of Movement Disorders Society of India and currently the editor-in-chief of the Annals of Movement Disorders. Please help me welcome Dr. Pal.
Thank you, Mr. Tran, and good morning, good afternoon, and good evening for all the viewers who have joined the webinar. And at the outset, I thank IAPRD for giving me this opportunity to speak in this webinar. So I'll just share my screen now.
Yes, please.
So today, in the next 20 or 25 minutes, I am going to speak on botulinum toxin injections in Sialorrhea. I do not have any conflicts of interest and I do not have any relevant financial disclosure to make. In this webinar, the learning objectives will be to be acquainted with the role and indications of botulinum toxin in reducing Sialorrhea, to get an overview of the methods of injecting botulinum toxin into the salivary glands, and to be familiar with the doses, efficacy, and side effects of this injection for reducing the drooling of saliva. Now, let us recapitulate the anatomy and physiology of the salivary glands. As you all know that we have two parotid glands and submandibular glands, which are the main salivary glands. And the parotid gland weighs about 25 to 30 grams and the submandibular around 7 to 15 grams. And we have the other sublingual glands here. So this parotid gland is situated between the, in a space around the angle of the mandible, between the angle of the mandible and the auricle here. And the submandibular glands is situated in the submandibular triangle between the anterior and posterior berry of the digastric. So our main target for injection are in these two glands because we cannot access the sublingual glands, though that participates also in salivary secretion. Now, this is another a three-dimensional picture. So to show that the parotid glands secrete the saliva to the duct here, and the salivary glands, actually both the glands, submandibular as well as parotid, have a superficial and a deep component, and then it combines with the sublingual glands and secrete the saliva. Now, what is the normal salivary secretion? It is about estimated to be about 1 to 1.5 liters per day. And there are two types of saliva secretion. One is the unstimulated saliva, which is about 0.2 to 0.4 ml per minute. And the salivary flow in response to a stimulus that is called stimulated saliva is approximately 10 times more than that. In the unstimulated state, the contribution, the majority, 60 to 70% is from the submandibular salivary glands, whereas in the stimulated saliva response, the 50% of the saliva comes from the parotid glands. And the salivary secretion, this is very important in relation to the patients with Parkinson's disease. There's exhibits at circadian variation and peaks in the late afternoon, and during the sleep, the flow is negligible. Now, this is the regulation of salivary secretion. You can see here that the parasympathetic outflow from the otic ganglion to the parotid glands and from the submandibular ganglion to the submandibular glands, this through the neurotransmitter acetylcholine will secrete the saliva based on stimulations received from the higher centers. And the parotid gland is mainly a watery secretion. It is serous acinine secreting amylase rich saliva, whereas the sublingual gland secretes a mucus viscous solution, and the submandibular gland is between a mixed population of acini with mucus and serous function. So now let us come to the point of sialorrhea. So what is sialorrhea? Sialorrhea is excessive salivation or excessive saliva inside the mouth, which ultimately drools out. So there are several medical conditions associated with drooling of saliva, and most are due to decreased swallowing of the saliva, which is spontaneous or voluntary. And this is typically found in amyotrophic lateral sclerosis, Parkinson's disease, and cerebral palsy. A total of about 70 to 78% of the patients with Parkinson's disease drool saliva. This results mainly from impaired spontaneous or reflex deglutition rather than hypersecretion. So most of the conditions in the neurological disorders are because the drooling is not because of hypersalivation, hypersecretion, but it is because of the lack of spontaneous swallowing. The factors determining drooling of saliva may include, especially this I'll be talking in mainly the context of Parkinson's disease. Those who are cognitively impaired have reduced alertness or higher stage of the disease. Those who have swallowing dysfunction, those who have a bent posture, especially the head, they have a higher drooling of saliva. And also if those patients who sometimes use anticholinergic drugs, this itself reduces the saliva secretion. If the oral hygiene is poor, hydration, it can increase the hypersalivation. If the hydration is poor, the mouth will be dry, and also an ambient temperature, because there is a difference between the sialorrhea in patients of Parkinson's disease in the temperate climates versus the tropical climates. So if you can see higher frequency of sialorrhea in patients of PD, those who are in the Western hemispheres, but especially in India and in the tropical countries, the hypersalivation or the drooling of saliva in patients with Parkinson's disease is not that frequent. Now, how to assess the sialorrhea? Before we go to the different treatments or injections, we need to assess the salivation, and there are various subjective scales. There are also objective scales are there, measuring the quantity of saliva and weighing the saliva. But most often we use the drooling frequency and severity scale, which is the frequency is rated in a scale of 1 to 4, and severity is rated in a scale of 1 to 5. Now, there are other treatments. I'll come to the botulinum toxin treatment, which is the main topic here, but there are other types of treatments which is not very satisfactory. Like one is conservative management and speech therapy, especially in context of Parkinson's disease, where you do behavioral modifications, you cue the patient to prompt the patient to swallow very frequently, but it does not help much. Other measures are like neck collars, head and head back wheelchairs, optimizing the doergic therapy. Then many people use anticholinergic drugs, especially triaxiphenidil, scopolamine, etc. But in elderly patients, they can have very serious side effects like psychiatric problem, and in patients who have benign hypertrophic prostate, there may be obstruction, urinary obstruction, or exacerbation of the glaucoma, etc. So anticholinergic drugs are not the mainstay of therapy for reducing the drooling. There are surgical techniques out there which has been abandoned, like resection of submandibular glands or ligation of the submandibular ducts, etc. And radiation therapy also has undesirable side effects. So most important therapy at present is botulinum toxin injection into the salivary glands. Now, how this concept arises, that the botulinum toxin will help reducing the salivation. The first well-recorded outbreak of botulism, the botulism, a disease where there is a dryness of the mouth, it was documented in almost in 1793. And later on in 1820, Dr. Justinus Kerner, he gave a very good monograph, he published a very good monograph on sausage poisoning, and he documented that in this condition, the toxin acts on the motor nerves and autonomic nervous system, and it causes dryness of the mouth. So based on this, when the botulinum toxin came into therapeutic use in 1977, you already know that botulinum toxin has 7 serotypes, and the main component which actually is active is the neurotoxin component. So based on this, there are different types of botulinum toxin available in the market, and there are different types marketed as Botox, which is monobotulinum toxin A, then Dysport, Xeomin. These are all marketed names, and botulinum toxin B is marketed as Myoblock. So these 4 major types of botulinum toxins are available. This has different types of potency, which I'm not going to go into details, but the activity, biological activity in most, which is also used for treating sialorrhea, is that if botulinum toxin A marketed by Botox is 1, then the Dysport has 1/3 the potency, and equivalent dose for Xeomin is almost the same, and for it is 50 times or 40, 50 times higher for Myoblock. And all the, these all 3 are dry powder, and here it is in liquid form, it is available. So now, as I told you that what is the usefulness of botulinum toxin for drooling of saliva? Botulinum toxin blocks the release of acetylcholine, and the major secretomotor fibers to the salivary glands are parasympathetic and susceptible to inhibition by toxin. Now, it was found in 1998 and 1923 also that in experimental animals, botulinum toxin reduces salivary secretion. In 1923, Dixon and Shefke showed that the tympanic nerve-induced salivary flow was blocked by the toxin in the cats. Now, as I told you that in botulism, there's a dry mouth is reported in about 93% of the patients, and dry mouth has also been reported in about 1/3 of the patients who received botulinum toxin injection, especially botulinum toxin B injection for cervical dystonia or other conditions. And the parotid glands are the largest and easily accessible salivary glands. So in 1997, Bushara proposed that intraparotid injections of botulinum toxin A may reduce salivary production in human subjects. Now, how to give the injection? So I'll come to that later on, but 2 main ways to give the injection to the parotids and the submandibular glands. One is by anatomical landmarks based on the published recommendations, and another is ultrasound guided direct injection of the 2 glands. So as I told you, in 1997, Bushara proposed that you inject the parotid glands, and he had given a how to palpate the parotid gland, which is lying between the ascending ramus of the mandible and the anterior border of the mastoid process, and you target that gland and give about 7.5 units of Botox. So based on this, I still remember that I was doing my fellowship with Dr. Khan in Vancouver. So Dr. Khan asked me that whether you can have any solution for drooling of saliva. And we came across this paper in 1997, and we started in 1998 to start doing this first pilot project, botulinum toxin A as a treatment for drooling of saliva in Parkinson's disease. And around the same time, there were 2 other groups, which was in Germany and by Jost et al. And by Bhatia's group in UK in 1999. So around this time, all the 3 groups started experimenting with botulinum toxin to reduce the salivation. And we published around the same time these articles in neurology. My article was published in neurology, and later this was in movement disorders and another in JNNP. So what did I do? I'll share first my experience, how we started the treatment. We injected this is the diagrammatic approach. You can see here that we injected the parotid gland. The main substance was injected at the point 1, and another 1/3 of the dose was given in the 0.2. So after clasping the portion of the parotid gland lying between the ascending ramus of the mandible and the mastoid process, as described by Bushara, the first injection was administered. And at the first time, since we were not very sure about what is the efficacy, we injected about 5 units here and 2.5 units here. Similarly, this is the anatomical landmark of submandibular gland, though at that time in the initial studies, we did not inject the submandibular glands. And here you can see the submandibular gland. It is more difficult to approach. It is, you have to, based on a reference line connecting the mandibular angle and the nathion. So here's the nathion and mandibular angle. It will be located about 20 to 35% from the posterior margin of the mandible and about 1.5 centimeter below the line of the inferior mandible. And the depth will be approximately 2 centimeters. So these are the two anatomical landmarks to inject the botulinum toxin in the parotid glands and glands. So this is a representation of the initial 3 studies. This is my study, which we studied about 9 Parkinson's patients. First, we gave about 7.5 units, and later, after about 8 weeks, we gave 15 units to each parotid gland. And we measured the saliva by putting dental gauge pieces inside the mouth, weighing the dry gauge pieces, and then after waiting for 5 minutes, what is the weight of the saliva, and then we did the same experiment after 8 weeks and after 16 weeks at the end of the study. So 8 patients had a very significant reduction in the objective saliva production, and at the end of the study, approximately 1/3 of the patients had reduction in the mean value of salivary production at the end of the study. And only side effect we found is dryness of the mouth. In the study by Jost et al., they injected all PD patients 5 units per parotid gland, and Bhatia et al., they injected Dysport, and there were 20 units per parotid gland in 3, and they also found similar results, and there were some complications of dysphagia, chewing difficulty, and dryness of mouth. So in my study, you can see here before the Botox injection and after the Botox injection, there was a very significant decrease in the mean weight of the saliva, which was before the injection was 2.3, and after the injection was 1.4. This is gram per 5 minutes of saliva secretion. But there was some, these are the individual patient response. You can see this is the first injection, and after 8 weeks is the second injection. And you can see in some of the patients, there's a drastic decrease in the saliva secretion at the 8 weeks, but some patients has a gradual decrease, and 1 or 2 patients did not improve significantly after the injection. So what the problem could have been, either we reduced, it was a reduced dose, or we could not target, because parotid glands are, there could be anatomical variations, and as age advances, there could be atrophy of the parotid glands. And you know that unstimulated saliva secretion, the majority comes from the submandibular glands. So when I came back to India, I did not find too many patients of Parkinson's disease because of the dry climate, but we did come across patients with amyotrophic lateral sclerosis, that is motor neuron disease, and patients with cerebral palsy. And here, this is a courtesy of my colleague, Dr. Rishikesh, who injected in the patients with So, other indications apart from the Parkinson's disease, definitely these patients has a very good improvement. Those who have difficulty in swallowing and the hypersalivation. You see the techniques. It's very difficult to give it to the children, and especially, so this is the technique in the parotid gland in the patient with motor neuron disease. So, so let us discuss now there are several unanswered questions at least 1 decade back, but now with 2 important studies which has come up, we have a clear guidelines of how and when, in what dose we need to inject botulinum toxin to decrease the sialorrhea. So what are the methods, which glands to inject, what doses, what frequency, what are the methods of assessing the efficacy and side effects? These are the things which we need to know. So let us discuss, I have told you about the anatomical guidelines. So anatomical guidelines is mainly targeted towards the parotid glands because it is difficult to inject very accurately the submandibular glands. But ultrasound guided injections is one of the one of the methods to inject very accurately in these glands. Though ultrasound needs other facilities, needs a you ultrasound machine, you need a technician, as well as it is costly. So the technical requirements are not very high. You need a linear transducer from 5 to 10 megahertz, and you can place the transducer at the mandibular angle, And just a few days of practice, the neurologists themselves can make out what is the parotid gland and the submandibular gland. The parotid gland is a point midway between the tragus and the jaw angle, and the submandibular gland, a point 1 finger width below the mandibular bone. So these glands contrast clearly with the surrounding tissue because of the homogeneous internal echo structure and the clear demarcation. So this was from Jost et al. In 2019. And you can see this diagrammatic representation of the salivary gland, submandibular gland here. Here is the target of the ultrasound, the transducer, and here the transducer for the parotid glands, you can see, and you can inject directly in these glands. So the ultrasound probe should be placed centrally over the gland. It could be injections can be made in plane or off the plane in the transverse axis of the probe. And if you give one injection, then usually it is given in the middle of the gland, in the bulk of the gland, and not near the salivary duct. And if there's several injections are given, then it can be distributed over the mandible accordingly. Now, this is a representation. You can see here that we are holding it for identifying the parotid gland, and here we are doing it to identify the submandibular gland. So this is the picture of this, what I showed you just now. This is one of our patients, parotid gland and his submandibular gland. Now, this is these are the photos from a publication by Abbott et al. Here you can see here. This is ultrasound image where you can see here, this is the needle, is the hyperechoic structure. This is a capsule of the parotid gland, and this is the parotid gland. And when you inject, you see this is the S, means the S is the solution of botulinum toxin. It looks like a hypoechoic. So you can identify the needle as well as the solution and the capsule and well demarcation. So it is definitely advantageous to inject by ultrasound guidance. So these are some of the initial papers started in 2001 with ultrasound guided. And here you can see here that this is the first ultrasound guided botulinum toxin injection in patients with neurological disorders. And each parotid was injected 15 to 40 units. Each submandibular gland was injected 10 to 15 units. And there was a beneficial response after about 3 to 8 days. And the authors concluded that botulinum toxin A was, ultrasound is a very good instrument to directly target the parotid and the submandibular glands. This is another large study where about 70 patients were retrospectively analyzed with different protocols of injection of the glands by ultrasound guided injections. And they found this protocol number 2, which I'll come to later on. Here, the protocol number 2 was the most frequently used study based on the efficacy of other protocols and published data. And this protocol was effective in about 68 to 100% of the patients. They injected 20 units into each submaxillary gland, and that is submandibular gland, and 2 injections of 15 units each into the parotid glands. Now, there are some studies which have compared the landmark versus ultrasound guided injections. And this is again from Jost et al. That the submandibular gland has a high variance of the size. It is about, variation is there, 1.6 to 15 ml. Often the location of the gland deviated from the expected location. Older people occasionally are more distant from the mandible, and the recommended injection point according to anatomical landmarks often does not correspond to the point identified by the ultrasound. And in the parotid gland, the variation was also high, but however, it is fixed in the region of the jaw angle. So both glands also undergo atrophy with age and with repeated injections. So this is a study. There are 2-3 studies I'll now share, which they have compared the ultrasound guided versus blind interparotid injection or blind submandibular injections, and they try to see the efficacy. This article was in 2004. And you can see here that the authors concluded that interparotid botulinum toxin A injections using ultrasound guidance may be an effective, easy, and safe treatment for Parkinsonian sialorrhea. So they definitely found that the patients who were injected by ultrasound guided interparotid injections had definitely much better response than those who were injected by landmarks. Then this is another study which was in 2017. In this study, they tried to find the accuracy of ultrasound guided and versus non-ultrasound guided botulinum toxin injections into cadaver salivary glands. And what was the conclusion? That in the parotid gland, the accuracy of the blind ultrasound guided injections was about 80% to 95%. So it was not bad. And there was no difference much between the ultrasound guided versus the landmark guided. But in the patient, in the submandibular gland injection, the ultrasound guided injections has about 95% accuracy compared to the blinded landmark guided injections, and which is about 50%. So definitely they concluded that if you have to inject the submandibular gland, the ultrasound guided injection is much better. So this is one of the studies where I'll come to later, which led to approval of FDA approval. This is a C-axis study where Xeomin was used, and about 50% of the patients had ultrasound guided and 50% did not have ultrasound guided. But in this such a big study, it did not show a clear difference in the therapeutic response of the two groups, with only the primary outcome measure showing a little superiority. So in this study, they found that there was not much difference between the ultrasound guided and the landmark guided injections. So this is the latest study of a comparison between the localization of salivary glands for botulinum toxin ultrasound versus landmark, and the authors concluded that the position of the salivary glands differs from the proposed landmarks and depends on the individual age and body weight. Therefore, they recommended that ultrasound guided injections is the best if you have to treat the parotids and the submandibular glands. So again, based on these, the Association of Scientific Medical Societies in Germany also have advised that sonographically controlled injection of botulinum toxin into the large salivary glands is recommended and is an effective and safe form of treatment with long-lasting salivary reduction for a wide range of ages and diseases. So I just told you about the C-axis study. That is, they have injected incubotulinum toxin A, which is marketed as Xeomin, and it is a phase 3 randomized double-blind placebo-controlled multi-center trial, 184 patients, and there were 36 placebo. Botulinum toxin A was used 75 units in one group in 74 patients, and another group had another 74 patients with 100 units. Most of them, about 70%, had Parkinson's disease, and both they found that in the 100 units group compared to the placebo, there was a significant improvement at week 4 compared to the pre-injection level. And there's a change in the unstimulated salivary flow by significant margin, and the global impression of change scale was also significant. And the lasting effect was about 16 weeks. So they concluded, and this led to the FDA approval of Xeomin for patients with Sialorrhea in July 2018. And FDA recommended that total units should be injected botulinum toxin 100 units. Parotid glands should receive 30 units each gland, and submandibular glands should receive 20 units each gland. And a possible replication can be undertaken after 16 weeks. So this was the first botulinum toxin to be approved by the FDA in 2018. Subsequently, in 2020, last year, the FDA also approved the use of incubotulinum toxin A in pediatric population to control Sialorrhea. Now, it was always found that botulinum toxin B also causes much dryness of mouth when injected for cervical dystonia than botulinum toxin A. So way back in 2004, Ondo's group had studied botulinum toxin B in 16 patients with PD using anatomical landmark injections. Parotid glands were injected about 1,000 units and submandibular glands 250 units each. And they found that there was a significant anatomically guided injections of botulinum toxin B into the parotid and submandibular glands appear to be effective in improving the Sialorrhea without compromising dysphagia in patients with Parkinson's disease. So there were, so even before the FDA approval, many investigators used to give botulinum toxin B, but this is one of the major studies which was published in last year, which led to the FDA approval of botulinum toxin B. So this was a study which is, multi-center study, about 249 adult patients, and 65% were having Parkinson's disease, and they injected almost similar units, and it was botulinum toxin 2,500 units, and one group got 2,500 units, another group got 3,500 units, and the placebo had 60 patients, 60 subjects in that. And they found the treatment with Rima 2,500 or 3,500 in adults was well tolerated and reduced the sialorrhea with the onset of the effect at 1 week after the injection. These data supported the use of Rima in the management of sialorrhea in the adults. So this led to the FDA approval in August 2019. The FDA recommended dose per gland, per parotid gland, 500 to 1,500 units, and submandibular glands 250 units, and total dose varying from 1,500 to 3,500 botulinum toxin B. Dry mouth and dysphagia was stated to be frequent side effects. So this is a summary of a recent publication by Jonathan et al. And they have summarized the 4 toxins, which 3 botulinum toxin A and 1 botulinum toxin B, and 2 have got FDA approval, and almost all the toxins are equally beneficial for injection in the parotid and submandibular glands to control sialorrhea. So, how frequently should we give the injections? Duration of the effects of the treatment reported to last from 6 weeks to 7 months. There is a lot of variation because of underreporting, because of not properly following up or difficult to follow up some of the patients, and because of lot of different type of patients, patients with cerebral palsy, Parkinson's disease, traumatic brain injury, problems inside the mouth. So with repeated injections, the time of effectiveness is prolonged. The mean duration of effectiveness can go up to 3 years. Frequency of injection is usually advised every 3 to 4 months and rarely every few weeks. Often the time of repeat injection is decided according to the response. And what are the side effects? Definitely the side effects are much less. There are many studies where no side effects have been reported. There are most of the studies where mild side effects are reported, like viscous saliva, dry mouth, difficulty in the motor control of the tongue, skin reaction, and aggravation of the previous dysphagia. And there are, as I told you, there are many studies are there where there are no mention about the side effects. So to conclude, I would say that injection of the parotid and the submandibular salivary glands using either botulinum toxin A or botulinum toxin B are efficacious for symptomatic control of sialorrhea. Onset of effect of botulinum toxin A and B starts within a week and lasts for approximately 3 to 5 months after the injection. There are no significant difference in terms of efficacy between these 2 toxins, A and B. The common adverse effects are most often is dryness of mouth, which is mild. Injection by ultrasound guidance rather than by anatomical landmark convincingly provide greater accuracy of injecting the submandibular glands. And in resource-limited settings and where there is no facility for ultrasound-guided injections, injection of the parotid glands using anatomical landmarks seems to be most appropriate. So I would like to acknowledge my colleagues and students of the Women's Parkinson's Disease and Movement Disorder subspecialty, and also to Dr. Rishikesh Kumar, who provided the videos. And I thank you all for your participation and attention. Thank you very much. I'd be happy to take any questions.
Well, thank you so much, Dr. Pal, for your presentation. And we're still waiting for some questions to come in. But while we're waiting, I wonder if there is other promising research down the road that about Sialorrhea.
Yeah, so see, there are most of the research which occurred was before the advent of the botulinum toxin, and I think this is one of the most important, and I am not very much aware of any other research which is going on which is better than botulinum toxin for patients of, at least for the patients of Parkinson's disease. There are relocation of drugs are there, especially those patients who have problems in certain ENT problems and otorhinological problems. And I think this is one of the best treatment as of now for treatment of sialorrhea.
Okay. So
there are treatment in resource-limited countries. Because especially in India, where botulinum toxin injection is not covered for all indications by the insurance companies, and to inject for botulinum toxin, it costs quite a lot. And if you have to give by ultrasound guided, it definitely costs much more. So we do not do by ultrasound guided. And if you have to inject only one gland, we inject only the parotid glands. And definitely the improvement is quite significant in most of the patients.
Also, I have another question, Dr. Pal.
Yes.
Earlier, you mentioned that patients in India show sialorrhea much less frequently than in colder climates. Could you elaborate on that?
Yeah, so this was my experience actually when I was in Vancouver for 2 years and later in Toronto. I found a lot of patients this is my experience in the Parkinson's disease. One thing is that the patients of Parkinson's disease in India is much younger, and the young onset Parkinson's disease is much prevalent in India, and the mean onset of patients of Parkinson's disease, onset of Parkinson's disease in India is about 7 or 8 years earlier than the Western population. So by and large, the elderly populations or elderly people with Parkinson's disease in India is much less compared to the Western population. And also because of the very dry climate in most of the parts of India, the dryness of mouth is quite common, and almost 40% of the patients actually are treated with anticholinergic drugs like trihexyphenidyl, which itself reduces the hypersalivation. And therefore, the drooling of saliva, unless in the very late stages of Parkinson's disease, is definitely much less in our country compared to the Western countries. It could be because of the ambient temperature, as well as use of anticholinergic drugs, as well as the lower age group of these patients.
Okay, one more question, Dr. Pal, and that is, are there any treatments you recommend for dry mouth?
Okay, so dry mouth, if it is as a part of, we had definitely faced dry mouth sometimes. So you tell the patient to, stimulate the saliva, and stimulation of saliva is nothing best. Rather, it is the most important thing is give a small piece of lemon juice or repeated lemon juice, which will stimulate the saliva, and hydration. This is the two things which I can recommend. Yeah,
Also,
how to decide the amount of botulinum toxin to be given for the parotid glands. Yeah, it's a good question. See, as I told you that about 20 years back, when we first started this parotid gland, we gave 7.5 units in each parotid gland, and later on 15 units. And in fact, in that, if you go by the landmark, like blindly, if you want to inject, you need to give a sufficient amount. Maybe the recommended FDA recommendation is 30 units in each parotid gland. So 30 units, if you give in each parotid glands, you should divide into two parts, 1/3 and 2/3. 1/3 may be given in the superficial part in front of over the masseter muscle, and 2/3 can be given in the deeper part. And if you want to give the submandibular gland, which I do not recommend, if you use only landmark guidance, then you have to give about 20 units in each submandibular gland. So I'll recommend that, since in the resource limited countries, we have 50 units vial, and that cost also quite high. So you can distribute as an initial startup, 25 units in each parotid gland can be a starting for a patient, and 25 units you can distribute into 15 and 10 and two parts. And later on, if there is significant improvement, you can continue with that. If there is no significant improvement, you can increase the dose to 30 units in each parotid gland.
Great. I think that's all the time we have today, Dr. Pal. And thank you so much again for your presentation. And as I mentioned earlier, this webinar will be recorded and available on demand for up to a year at our website, which is www.iaprd.org. And before I say goodbye, I'd like to invite you to the next webinar, and our schedule will be on our website as well. So thank you.
Thank you.
Thank you, Dr. All right, bye-bye.